Welcome to the Functional Medicine Foundation's podcast, where we explore root cause medicine, engage in conversation with functional and integrative medicine experts, and build community with like-minded health seekers. I'm your host, Amber Warren. Let's dig deeper. Welcome back, everybody. I'm here with Dr. Mark Holthouse to go on another yet deep dive on cardiometabolic medicine, which we're so excited about. So Dr. Holthouse, MD, IFMCP, is board certified in family and integrative medicine and a certified functional medicine practitioner, and he is currently our chief medical officer. He is passionate about delivering proactive patient-centered care. Dr. Holthouse focuses on addressing root cause rather than merely managing symptoms. Frustrated with the limitations of traditional medicine, he transitioned to a healthcare model that prioritizes preventions, cures, and lasting wellness over simply prescribing medication. Dr. Holthouse is dedicated to empowering patients to achieve optimal health through personalized and holistic approaches. He currently specializes in cardiometabolic medicine, obesity, and metabolic medicine, and hormonal health for both men and women. And also anti-aging.
Peptides, dabbling.
Anti-aging, peptide medicine, the list goes on and on.
Fun stuff.
It's awesome. So we're here to focus on, again, the cardiometabolic piece, and specifically talking about a new-ish topic that's been discussed in our realm and some new data that's come out that we are going to find our way through and discuss. A new study that was released in March.
Yes.
So we've touched on this idea of lean mass hyper-responders. Scroll back. I don't remember what episode number it was. Maybe we can link it here, but a cardiometabolic talk where we discussed ApoB and Lp(a) and the concerns with high particle number. And Dr. Holthouse mentioned these lean mass hyper-responders, but today we're going to take a deep dive. And since then, there's been a study that's been released. But it's worthwhile to go ahead and go back and define what a lean mass hyper-responder is. So what is that? Take it away, Dr. H.
Yeah, this is a bit of a lightning rod.
Yes,
I hope I don't get run out of Idaho on a rail. But, I talk about this because I love my carnivore and keto patients.
Yeah.
Why? Because they are so motivated to be healthy. They're willing to do almost anything.
Yeah.
There's been an information gap, I think, between the science and this study that came out in March of 25, the KETO-CTA trial, which has been looked forward to for a while now.
Yeah.
Was really taking some of the promoters of the lean mass hyper-responder phenomena and putting it to the test.
Yeah.
The lean mass hyper-responder is a subgroup of athletic, lean, healthy patients, both men or women, who don't have diabetes, who don't smoke, who don't have, high blood pressure, problems with fatty liver. They're generally, when you define this, and it's really a self-described handle, this is not a scientific name. One of the gentlemen that's promoted this heavily in the literature and been on a lot of different podcasts on this topic really came up with the term. The idea is that they have an LDL cholesterol that's 190 or higher. Many of them are as high as 200-300. Granted, normal is less than 100. They've got HDL levels, that are above 60, and often triglyceride levels that are very, very ideal, less than 80. And this kind of defines this group of patients that is eating a very low carbohydrate keto diet. This study was a 24-month, actually it was a 1-year trial. They had been on keto diets for 2 years prior. It took them a long time to find 100 people, that's all that's in the study, to follow for a 12-month period that met all the health requirements. So these are specimens. These are people that you see, that are 12% body fat, 15% body fat, that are absolutely ripped, shredded.
And very aware of their health.
Very health conscious, who often don't eat any carbs, including vegetables, maybe a little bit of fruit and things like this. So they're not folks that have had heart disease. These are not people that necessarily have high genetically acquired cholesterol. These are folks that had relatively normal ApoB and LDLs prior to eating this style of a keto or carnivore-esque plan. and then became abnormal on their labs. So incredibly healthy. Took them a long time to find people that met this criteria, that had good numbers, started eating a certain way, and their numbers went kind of bonkers. And the study premise was, are those people, is it necessary for them to pay attention to their LDL and ApoB, or does it not really matter when it comes to plaque and cardiovascular risk? That was their hypothesis, that they didn't think it maybe mattered. So we wanted to just go over that particular study and give a bit of a critique. The way that the authors on social media and the way it was rolled out was a bit disingenuous when you look at the actual science and the details of the results. It was very, very, they ended up really kind of disproving their hypothesis, in fact. So we kind of go through tonight the idea, the things that make this maybe not what it seemed on its face, the way it was presented.
Right. Yeah. Okay. Good way of putting that. So what the authors did, what was their primary endpoint?
So their primary endpoint that was stated, and this is what you do with a clinical trial ahead of time, was to look at the change in the non-calcified plaque volume over a year's time in these 100 healthy people who had very high LDL and ApoB cholesterol. That was the stated primary outcome. What was interesting is that they did a post hoc analysis after the results came out, and they realized that the results were not favorable to their hypothesis, and they changed the
switcheroo.
Yeah, they did a switcheroo on what actually they were looking at, and instead of looking at the median change over a year from baseline plaque, non-calcified, the stuff you can't see in a coronary artery calcium score over the year, they looked to see, well, this is going to be a study that instead looks at what's a better predictor of heart disease. Plaque that you already have as a baseline starting, or ApoB LDL. So they actually, and that's taboo in the clinical research world, to switch your primary goal after you see a result you don't like.
And so what's ApoB?
So ApoB is basically a protein that's on all the plaque-forming atherogenic particles of cholesterol in your blood. So things like triglycerides, LDL, have ApoB protein stuck to it. Things like VLDL and some of these other particles, intermediate density lipid particles. So it's a protein that's representing all your plaque-forming lipoprotein particles in your blood. So it's more approximating the risk of actual cardiac disease than either LDL or triglyceride or non-HDL cholesterol, these other measures that we have for risk. It's now recognized as the most accurate at predicting cardiac risk and plaque.
So they looked at baseline ApoBs on these?
They did.
These 100
everyone had a
participants.
baseline ApoB. They had LDL cholesterol and some other labs that were looked at. And as part of the entry criteria is that you're on a keto diet, you're meeting, these criteria of a lean mass hyperresponder. So their LDLs were, 190, 200, 250 and up. Again, normal being less than 100.
Right.
Yeah. So it was a group of people otherwise very healthy whose diet had made their cholesterol do this. And that was the initial group.
And so what did we see? What kind of changes did we see? And how were they measuring those changes?
So
we want to touch on that too.
Interestingly enough, they stated that the change in non-calcified plaque volume over a year was their primary goal, but nowhere in the paper was it mentioned. Only after other scientists critiqued their results and said, where's your primary endpoint? Was it reluctantly shared. And what they shared was an 18.8 cubic millimeter increase in plaque thickness in these 100 people over the year. Now, this was a median level. There were people above that, even worse, and people below that. And the issue there was that when you look at the technology they used for this test, which is the clearly coronary CT angiogram, which looks at non-calcified plaque. It's one of the only technologies that's doing that.
And we care about that because the non-calcified plaque is more dangerous, more atherogenic than what we can pick up on a coronary calcium
to
rate.
Rupture. Exactly.
Okay.
Yeah. And there were other cohorts, other studies done using that same CT AI technology looking at non-calcified plaque. And what they found was that change over a year was about 4 times faster than other folks that were healthy who didn't have such high ApoB and LDLs like these lean mass hyperresponders. So they were laying down this non-calcified plaque 4 times faster.
Very concerning.
Than people that were matched in other studies. The problem is this wasn't even really a trial because there was no randomization. There was no control group.
No control, okay.
So everybody that was studied was exposed to really high levels of ApoB and LDL. There wasn't a group of lean, healthy folks with normal levels.
Why do you think they didn't have a control group?
It's a good question.
ApoB of 75 with an LDL of 95, that would have been a really good group to study alongside this group of 100. Okay.
So we've had to go and look at other similar studies, cohorts with healthy people matched and without diabetes, without heart disease. And what we found, in fact, was much lower rates of non-calcified plaque being laid down.
And so we do have that data with a clearly looking at the non-calcified.
Yes,
okay,
using
good.
the same technology.
Good. Yeah.
Part of the problem is they switched their primary endpoint.
Yeah.
They didn't publish it. And then when they did publish it, they talked about just looking at the median, which when you use the median instead of an average, you're protecting yourself from outliers.
Right.
Because it's really just kind of that number that's in the middle as opposed to taking all the values and dividing by the total, which would have looked even worse. And some people estimate that instead of 18%, it would have been somewhere between 20 and 30 millimeters cubed, which was far
significant. That's a significant
more.
difference.
In fact, it was 5 times worse than the authors predicted it was going to be before doing the study.
Wow.
Yeah. So pretty outlandish results. And so, making a switch in your primary endpoint to something that they call it an exploratory observation, looking at, hey, is baseline plaque and ApoB, which is better at predicting plaque progression.
Right.
It's a smokescreen. It's a gaslight. That's basically what went down.
So I have a question going back to the original definition of a lean mass hyperresponder. I have a feeling there's a lot of people out there that would have an LDL that would fit in this category with trigs that would be optimal. In this case, you're saying below 80. But genetically speaking, I feel like there are a lot of I'll speak for my clients. I have a fair amount of clients that would fit this category, except for they have an HDL that is low and not high. And a lot of that I think is genetic reasons. And I'm kind of digging into that literature right now on low and potentially too high HDL. So how do they fall out of that? Like, how do we know? I guess I'm asking for a more sharpened definition of a lean mass hyperresponder.
Yeah. So if you don't have an elevated HDL, you don't make the cut.
Okay. So you wouldn't fall into that category.
60 for a guy is a relatively high HDL. And a lot of these people are at, 60, 70, 80. And it's because they're so lean.
Right.
There is certainly some genetics to it. For the females, the estrogen has a big role.
For sure.
In raising HDL. So there are some predisposing factors that speak to HDL. The main issue is that when you look at people that have HDLs of that caliber and triglycerides that are less than 80, the ratio of triglyceride to HDL, that's less than 2.5 is clearly not somebody who has insulin resistance.
Right.
And so they don't have any evidence of what we call metabolic disease or metabolic inflexibility. These are people who can use ketones and fats as well as they can use glucose.
Absolutely.
Which is, they're a minority of the population.
They are, yeah.
So what's so telling about this is that, what happens if you take somebody that's got these kinds of numbers, who's not a lean mass hyperresponder, has more than 4 times the rate of laying this non-calcified plaque down. This is an elite group of people. So
that's a great point.
It makes you realize, wow, how many people who think they're lean mass hyperresponders that are out, CrossFitting and they're carnivore and they look amazing. Their body compositions, to look at them, you'd think, well, I want to be like that.
Right.
But yet inside this chaos is going on and they're laying down. And they might not even be as healthy. Their HDL might be 40. They might have borderline high blood pressure or blood sugar.
That's a good point.
They're going to have even worse risk, we know, from many other studies than this group. So if you take the elite who have this adopted diet that artificially raises their ApoB and LDLs sky high, this study helps us now to kind of confirm, and there'll be more studies that need to come along that are longer term to look at absolute risk. But now the burden of proof after this initial study, they haven't proven really anything about ApoB and LDL and its relationship to plaque progression. Why? Because everybody in the study was exposed to the same high level. It'd be kind of like saying people who smoke 2 to 4 packs of cigarettes a day, it really doesn't matter for people who smoke, a few cigarettes a day. If you're not comparing the non-smokers' data, you'd think smoking's not a risk to lung cancer.
Yeah.
But with that same logic. So the burden of proof was to show that this group of highly healthy folks with this particular lab abnormality was somehow protective, and in fact, it showed the opposite. Yeah.
So clinically, how are you changing your verbiage with some of these really healthy clients that are keto-ish or full-blown keto?
So I tell them, look, the reason that you're not inflamed, the reason that you're as svelte and as ripped as you are is not because you're eating meat 3 times a day or 15 eggs a day and denying yourself anything green that has fiber or of color that grows. That's not why you're healthy. The reason that you're healthy is because you're avoiding simple carbs. And when you're eating a lot of those low-carb, high animal product foods, your satiety is amazing. You're full. You're satisfied. It's easier than doing a lot of vegetable prep. It just is. So I say, as does now Paul Saladino and others, hey, add some squash. Add some yams. Add some cruciferous veggies. Some of these things that aren't high in phytates and oxalates and antimetabolites and sky high in lectins for those that are sensitive to those things. And it's going to help lower these numbers, these ApoB and these LDL. So it's really helped with saying, look, we now know that you're not immune.
Absolutely.
Even at your amazing observational looking at you, it still matters. And in fact, it appears to matter even more. These folks were compared to other studies, the Paradigm study, which looked at your 10-year predicted atherosclerotic cardiovascular risk, either being low, intermediate, or high risk, as far as how much of their, what we call percent atheroma volume in their coronary arteries. And they had a 1.6 baseline with a 0.8 cubic millimeter increase in a year, which was 50% increase in the thickness of the atheroma volume in their arteries over a 12-month period. Come to find out, that's on par with people that have intermediate and high 10-year risk of having an event, a cardiac event, not low risk, folks. So none of the folks in the trial had low risk.
Yeah.
They were all intermediate or high risk when it came to following the percent change in their plaque volume. So we looked at non-calcified plaque, and we looked at something called percent atheroma volume, which is just looking at what percent of the volume of the total artery was involved with plaque of both types.
Okay.
Yeah. So a little bit different measurement, but both results were definitely a cause for pause.
Absolutely.
And certainly not a justification to say they're immune to LDLs and not important. And what really stemmed me into going to the science and really delving into this study, I have so many clients that say, well, ApoB doesn't apply to me. LDL doesn't apply to me.
Yeah.
Because an influencer on a podcast said that it doesn't matter.
It doesn't matter. Yeah.
So they're taking this much of the science and misapplying it, and just the rampant
doing whatever they want.
Misinformation has been unbelievable on this topic. So it's been I think, a wonderful effort on the part of the study designers to try to gain insight into this small group of the population.
Absolutely.
It needed to be done.
For sure.
We need more studies.
Yeah.
But
we just need to be really transparent about the results.
Exactly.
Yeah.
To say that this study in any way, shape, or form with no control, all of them having the same exposure to high,
Right.
Has any correlation with that particular risk factor being a predictor of plaque progression is just nonsense.
Yeah.
If we were to have had a control group,
it would have been different.
Where we had metabolically healthy folks with more normal levels of ApoB and LDL.
Knowing what you know about cardiometabolic disease, if they had 100 people that were metabolically healthy, LDLs under 100, HDLs above 60, trigs even under 100, what do you think the outcome would have been?
The prediction based on other cohorts that have looked at that, patients without any metabolic disease, heart disease, diabetes, that were similarly matched, those cohorts show, wait for it, less than 5 millimeters in a year cubic. So it's it's a 4-time, almost 4-time, 18 of non-calcified versus 5. And for the ones that were on recommended treatment, including pharmaceuticals to get the ApoB and LDL down, minus 21.
Ooh, yeah, you can't argue that data.
Minus 21 cubic millimeters. So they went almost as far the other way, negative, as the lean mass group
went
did.
The other way.
Yeah, so that's a huge swing.
Yeah, it is.
When you look at it that way. So,
and you said they were on nutraceuticals and pharmaceuticals?
These were, in the studies that I reviewed, these were people that were on prescriptions.
Okay.
Yeah,
okay.
so I'm assuming they're talking about statins. Yeah.
Okay.
And that's a whole nother discussion.
Yes, it is,
And how we use those in different ways and microdosing, or we use alternatives.
Absolutely.
We have other things we can do. The key is do what you can to get that ApoB and that LDL down. In a lot of these folks, if it's diet induced and you simply add a little bit of those complex carbs that I mentioned, you'll see a pretty dramatic improvement with ApoB.
Well, and that's what I was going to mention when you're looking at these 100 people that had already been doing this for 24 months.
Yeah.
I wanted to see their gut microbiome and how that was influencing their LDL and ApoB.
Yeah.
And if you could have just modified their gut microbiome with some insoluble fiber, that could have made such a significant difference in there. We know the data on that. So there's so many different studies I want them to do based on this, just knowing what we know about many other aspects.
It's certainly not done. And I take my hats off for them having the courage to do this study. It needed to be done.
For sure. Have they spoken out since then? Have they said anything?
No, it's been pretty quiet.
Okay.
There was a huge backlash.
I saw that,
after it came out in March for probably the first 2-3 months. And as of June, it's kind of died down.
Yeah.
And I think what people were going to say has been said on both sides.
There's not much else to say,
What was disingenuous is that they said, well, we just use the ApoB and the basic baseline plaque, comparing both of those as a predictor of plaque progression as an exploratory interest. But then they chose to title their paper that way.
Oh, yeah.
Yeah, and it basically, the title was something like, is it baseline plaque predictive of plaque progression? Yes.
Yeah.
ApoB, not so much. So it was very deceiving.
Yeah, it was.
But they used their exploratory, primary goal switcheroo. That was when we called them out on it. People called them out on it as they said, "Oh, it was just exploratory. We didn't mean to say there was any causality or either way being insinuated." Well, you called the title of your study
paper just that,
by that phrase.
Yeah.
So it appears to be that there was some intentional shenanigans going on because it didn't come out like they wanted. But a negative study is as good as a positive.
Absolutely.
It's all information.
And I wish they would have seen that, yeah.
I think there are so many other spin-off studies that could be done. Microbiome, as you insinuate, the reason we care about that is that a lot of folks that don't eat plants, fiber, that's how we feed and thrive our microbiome. And that's one of the criticisms of many of carnivore outside of cardiovascular risk is that the microbiome really suffers, which is a whole nother topic. So if somebody had a way to evaluate that as another comorbidity or another variable and control for that, that'd be wonderful. They just need controls, period.
Yeah. Lesson learned. Lesson learned. Yeah, for all of us.
Yeah.
Well, so intriguing. And I know there'll be so much more to come on this, on just, what we're seeing with this cardiometabolic stuff, because we all need to remember that what's the number one killer of men and women?
Oh, yeah.
It's still cardiometabolic
Everywhere.
disease. So
everywhere.
we have to pay attention to this data.
Yeah. And I just take my hats off to folks that are doing low carb diets, that are trying to avoid what their parents and their friends, and, they see the disaster, which is the standard American outcome of eating the way we do. I take my hats off. I encourage them. It's just, I think that, that understanding that piece wasn't important. This answers a little bit, I think, to the contrary. And that maybe there is a path forward by implementing just a little bit of complex carb. And what I want to see as a follow-up study is a gradation of, where is that sweet spot where how much complex carb, veg, and fruits you need with something like that. I think the people that are cycling on and off keto and carnivore probably are getting as close as you can. And I'd like to see that study.
Yeah, that would be good to see.
What happens when you're not doing 24 months of keto, when you're doing
just 8
2
weeks.
months, 8 weeks, and then you have some
as a reset.
Reset. And it needs to be a longer duration study to watch what's going on.
Yeah.
Not just with ApoB and LDL, but
CRP,
what's
HSCRP,
going on with these plaque volumes. It's going to be difficult, to measure serial changes in non-calcified plaque volume and atheroma, within a shorter time of a year.
Yeah.
But I think that there are some metrics that we could look at to get a little bit better idea.
Well, and I think the other take-home message, just to pull back a little, is also, hey guys, and some of you gals, you're 42 years old, carnivore-ish, keto-ish, in the gym a ton, looking great, feeling great, hormones are optimized. Get in and look at your labs. Because a lot of people don't even know where they stand. Do you fall into this category of being a lean mass hyperresponder? You probably want to know that. Even though this, like we said, the study outcome was poor, but there's so much more to be known and so much more we need to study. Get your biomarkers done.
Well, I don't even fall into that category myself. My LDL, it runs high, but not that way. My HDL doesn't meet, or trigs. My trigs meet the criteria. That was the only one. And my own clearly CT angiogram, I had some stuff there, and none of it was calcified. It was all non-calcified. My CAC score, of course, calcium was 0, and I would have been reassured when in fact that wasn't the case. So it's really been, I think, kind of a wake up. But it's helpful, I think, to look at labs. And I also tell people, look, if you're higher risk, you definitely don't even meet the criteria. It's going to be as bad as this study or worse. Right. Get an image. Yeah. Get a scan. Yeah. Get it clearly done. The images don't lie. Yeah. Because each of us are individuals and we're different. And so to just say as a categorically hey, people that do this, that have these labs, all have the same risk.
Nope.
It's just not personalized medicine.
Yep.
So get some labs, come in, let's do a meaningful image. A lot of these things aren't covered by insurance, but hey, it's your life.
It's your
number
life.
one cause of death.
Yep.
If you get one, it's fine. You don't necessarily have to redo it. If you get one that's got some things and you repeat it at 3 to 5 years, it can really help guide what your program looks like.
Right.
Based on evidence, not just social media.
Yes. It's a great way to end that. Yes. Great. Thank you so much, Dr. Holthouse. This is so
fun
interesting.
stuff.
And I love to, poke holes in all these things and all the data. And yeah. Science has become an interesting thing nowadays, hasn't it?
For sure. Thanks.
Thank you so much
Thanks,
for joining
guys.
us. Are you looking for high-quality supplements? FunMedShop.com is carefully curated by the wellness experts at Functional Medicine of Idaho. You'll find high-quality supplements to support your health and optimize your body's natural functions. Rooted in responsible sourcing and utmost commitment to purity ensures that you're getting products that are not only effective, but also safe and reliable. Plus, you'll find our own line, Functional Medicine Foundations, which is carefully formulated using the best ingredients available so you can trust that you're giving the body the support it needs. Visit funmedshop.com today and take the next step in your health journey. That's funmedshop.com. Thank you for listening to the Functional Medicine Foundation's podcast. For more information on topics covered today, specialties available at the FMI Center for Optimal Health, and the highest quality of supplements and more, go to funmedfoundations.com.